Hello everyone, my name is Dr. Kush Nandwana and I'm DNB General Surgery. I have passed the General Surgery or Surgical Discipline from National Board of Examination in my first attempt, and in throughout my surgical practice or surgical career I have come across many cases and many topics and many things that I will share you in these lectures. Okay, so you will be getting the entire surgery, the general surgery, GI surgery, and other all other specialties of subspecialties of surgery in these recorded lectures. So be careful while listening these videos. Have a uh, notebook and pen along with you so you can have a good notes. So these notes will be very helpful and very beneficial when you will revise the entire subject of surgery. And these notes are basically taken from or made from Belly of Love 28th edition and Sebastian latest edition. Okay, so first topic we will start, that will be surgical nutrition. The first topic we will start is surgical nutrition. Surgical nutrition. Surgical nutrition. Okay. The first and very important subject of general surgery is surgical nutrition. In this topic, we will discuss the entire mode of nutrition in the surgery, general surgery, and different type of nutritional assessment. Along with this, there are different mode of nutrition in the field of general surgery, and every kind of nutrition has its own complications, its own pros and cons. That along all the things we will discuss in surgical nutrition. Okay, so first we will start with nutritional assessment. Nutritional assessment. Okay, bacho. Nutritional assessment we will start first. In nutritional assessment, there are two type of assessment. First is anthropometric assessment, and second is biochemical assessment. Anthropometric and biochemical assessment. There are two type of assessment: anthropometric and biochemical assessment. Okay. In anthropometric assessment, there are certain points we will discuss, and in biochemical assessment, some important things we will discuss. First is in in anthropometric assessment, it's a poor indicator. It's a poor indicator of assessment. Okay. For second, just like example is skin fold thickness. Skin fold thickness is the example of anthropometric assessment. Okay. Next example, mid-arm circumference. Mid-arm circumference. These two are anthropometric assessment. Okay. Second, in biochemical assessment, no single reliable biochemical marker is present. No single reliable biomarker is available. Okay. Second, but some biomarkers are considered. Example, serum albumin. Okay. And second, serum pre. If you are taking a patient for surgery and serum albumin is low, it means you will consider that patient is having a poor nutritional status. So before surgery, we have to give albumin to the patient and we have to build the surgical status, surgical nutritional status of the patient. Okay. Second, one tool is there that is discussed in belly, must tool. One tool is there that is discussed in the belly for assessment of nutrition is must tool. Okay, bachcho? In must tool, the full form is malnutrition, malnutrition, universal, universal screening tool. What is the full form? Malnutrition Universal Screening Tool. Must tool. Okay. In must tool, total 3 points are considered. Okay. 3 points are considered. First is BMI. Okay. Second is weight loss in 3 to 6 months. Okay. Second point is weight loss in 3 to 3 months. And third is acute disease effect. Acute disease effect. These three things are considered in must do. Okay. Question can be asked like which is not considered as a part of must do. Like three options will be given and you have to choose one part. Okay. Three things are there. First is BMI, weight loss, and acute disease effect. Okay. You will give 0 marks if BMI is more than 20. You will give 1 mark if it is 18.5 to 20, and you will be given 2 mark if it is less than 18.5. Okay. This numbering, these marks are given according to BMI. Okay. In weight loss, 0 marks is given if weight loss is less than 5% in 3 to 6 months. One is given if it is 5 to 10% of weight loss in last 3 to 6 months. And two is given if it is more than 10% of weight loss in last 6 months. Okay. In acute disease effect, a score of 2 is added. A score of 2 is added. Okay. If acute, if nutrition intake decrease or no intake for more than 5 days. Okay. There are three things considered. Score of 2 is added. Score of 2 is added if nutritional intake decrease or intake of or no intake for more than 5 days. Okay, then 2 is added. So according to this formula, according to this, okay, if there are three consideration are considered. How it is considered? If total score or if total score of all three above points are, it can be 0, it can be 1, and it can be 2. Okay, there are 3, 2 or more. There are 3 possibilities of their key total score of all these 3 points are, all these 3 points are 0, 1 or 2. Okay, in this situation, what we people will do, we will consider 3 things. If it is 0, we will consider it as low. If it is 1, it is medium, and if it is more than 2, it is high. Okay, in 0, we will do care, routine care. Okay, in 1 score, we will hospitalize and observe. And in high score, we have to treat the patient. Okay, this score is sometimes asked in the exam. तो आपको ये याद रखना है. What you need to remember is, what you need to remember is, in must tool there are 3 types of uh, points considered. First is BMI, second is weight loss, and third is acute disease effect. In BMI, if it is more than 20, we will give 0 marks. 18.5 to 20, it is 1 marks, and less than 18.5, 2 marks. Less than 5% weight loss, 0 marks. 5 to 10% weight loss, 1 mark, and more than 10% weight loss, 2 marks. Okay, and 2 marks is added if acute disease effect is present. Okay, in this situation, if it is low, then we will give routine care. If it is medium, we will observe the patient, and if it is high, we need to treat the surgical malnutrition. Okay, next. Now the next important point is BEE. BEE is basic energy expenditure. Basic energy expenditure. Okay. In BEE, what we will consider, the normal value of BEE is 20. Normal value of BEE is 20 kilocalorie per kg per day. This is normal value of basic energy expenditure. Okay. But in special cases, okay, we have to multiply it. So multiply it in different way. Just like in in mild sepsis, in mild sepsis, we have to multiply it by 1.4 times. 1.4 multiplied by basic energy expenditure. It is 1.4 time of basics. Okay. In severe sepsis, it is 1.8 time of basic energy expenditure. Okay. And in severe burn, it is 2 into BEE. Means in severe burn, 2 times of basic energy is required. 2 times of basic energy expenditure is required. Means almost 2 times energy or nutrition is required. That is why in burn cases, this nutrition is very important. Okay, and nutrition is very. Now, the next important topic is enteral nutrition. Enteral nutrition. Enteral nutrition means which is given through the nutrition which is given through the alimentary canal is called as enteral nutrition. Okay. The most important thing of this nutrition is it is more physiological, more physiological. It is more physiological. Second is it is cheap because it can be prepared at home. Third is it keeps microvilli patent. Microvilli patent. Okay. It keeps microvilli patent. Four important thing is prevents translocation of translocation of gut bacteria. Okay. When we will study about intestinal obstruction, this translocation of bacteria is very, very important. Okay. And it maintains enterohepatic circulation. Maintains enterohepatic circulation. These are the pros of enteric circulation. Okay. The best route it is given through is oral. Okay, best route is oral. If oral route is not possible, if oral route is not possible, if oral route is not possible, then we will check two things. Like we will check the duration. Like for how many duration we need to give the this this enteric nutrition. Okay. If we need to give it for less than 2 to 3 weeks, or we want to give it for more than 3 weeks. Okay. There are two things. Best route is oral, we will give, but if oral route is not possible, then we will consider two possibilities that for how many weeks we want to give the nutrition. If we want to give it for less than 2 weeks or more than 3 weeks, it is called as, in this case, we will see two things. First is good gastric emptying present, good gastric emptying is present, or poor gastric emptying is present. Poor gastric emptying is present. Okay. There are two possibilities. We want to give it for less than 2 to 3 weeks, or we want to give it for more than 2 to 3 weeks, less than 2 weeks or more than 3 weeks. Okay. So in that case, we will see two things. First is gastric emptying of the patient, if it is good or it is poor. Two things we will see. Same here also we will see two things: poor gastric emptying or good gastric emptying. Okay. If we are planning for less than 2 to 3 week, if we are planning for less than 2 to 3 week and gastric empty is good, then in that case we will put a ng tube. Okay, we will put a ng tube. If gastric emptying is poor and we are planning for only 2 to 3 weeks, then we will put nasojejunal tube. Nasojejunal tube. Okay. NG tube is nasogastric tube, just like rice tube, and nasojejunal tube if gastric emptying is poor. You can, like, if you will simply think about the basic concept, you will get to know about these basic idea. Just like if gastric emptying is good, you can put the tube in gastric. Okay, because if gastric emptying is good, whatever you are giving in stomach will automatically go in the further alimentary canal. But if it is poor, you need to give directly in jejunum because stomach is not emptying properly. Okay, if you are giving, if you are giving for more than 3 weeks, or then we will consider for two things: gastric emptying is poor or it is good. If gastric empty is good, we will put feeding gastrostomy. Gastrostomy. Okay. And if it is poor, we will put feeding jejunostomy. Same concept, jejunostomy. Same concept. If gastric emptying is poor, then stomach is not emptying properly, so we need to put the tube in the jejunum. So gastrojejunostomy. Okay, and if it is good, gastric emptying is good, we need to put the tube in stomach. Okay, and this is more physiological. This is more physiological, but increased chance of aspiration. And same vice versa, it is less physiological but decreased chance of aspiration. Okay, these three things we have to consider in our mind. If oral route is not possible, we have to put NG tube or nasojejunal tube if we want to give it for less than 2 to 3 weeks. If we want to give it for more than 3 week duration or long duration, we need to put the gastro uh, feeding gastrostomy or feeding jejunostomy. Okay. Now we will discuss one thing: how the rice tube is inserted in the patient. Okay. First of all, we need to understand the concept behind the rice tube insertion. Okay. You easily understand that if you are giving the nutrition to the patient for short duration, in that case we will put the nasogastric tube, rice tube. Okay, so for the rice tube insertion, we need to understand some basic concepts of the rice tube insertion. Okay, first, the most important point is color of rice tube, color coding. Okay, color coding. There are different type of color codes Raj to present that we will discuss in further slideshow. In slideshow, I will explain you the entire color coding of all rice tube, all Foley's catheter, everything. But right now, we need to learn color coding like 16 number rice tube is usually saffron in color, and sorry, 14 number is saffron in color and 16 number is green in color. Okay, so this ratio we need to put the in the patient. Second, length of the ratio. Length of the ratio. Which type of ratio should be inserted? Okay, which up to which length it should be inserted. The basic concept is from nose, from nose to tragus, from nose to tragus, and tragus to the G-sternum, like epigastrium. This length is measured from nose to tragus, and tragus to epigastric length is measured. This nose to tragus, nose to tragus, and from tragus to epigastrium. Epigastrium. This is the way. And third is position. In which position rice tube is inserted? First is sitting position is good. Neck should be slightly flexed, slightly flexed, slightly flexed. Okay, slightly flexed. These three things we need to keep in our mind. Fourth is confirmation. Confirmation that it is in the stomach or not. Okay, if you are going to feed the patient and if you will put the rice tube in the uh, trachea, then the entire feeding will go in the lungs and patient will die. So confirmation of the rice tube is very much important. Okay, in confirmatory method, first aspirate the tube. Okay, aspirate the tube. If gastric content is coming out, then it is in the stomach. And second is push the air. Push the air and auscultate. These three things are कंसिडर. एक और अपने पीजी टाइम की प्रैक्टिस की मैं आपको एक बहुत बेसिक कॉन्सेप्ट बताता हूँ स्टूडेंट्स. यूजुअली जब राइस ट्यूब इज इन द राइट पोजीशन and you will ask the name of patient, he will able to tell his name very comfortably. Okay, and if you are asking the name or if you are asking anything to the patient and he is not able to speak anything, it means you are in the wrong place. It's a basic and very basic idea. When you will go and when you will do your post graduation in surgical specialty, then only you will get to know all these small things. Okay, then next we will discuss about feeding jejunostomy. Next we will discuss about feeding gastrostomy and feeding jejunostomy. Gastrostomy and feeding jejunostomy. Okay, what is gastrostomy? In gastrostomy, what we people will do, if consider it is the anterior abdominal wall, ये आपकी पेट की wall है, anterior abdominal wall, or this is the stomach. Okay, if you will put the tube directly in the stomach and you are feeding from here, it is called as feeding gastrostomy. Okay, if you are feeding here, it is called as feeding gastrostomy. There are like some methods are there. Okay, first method is stem method and second is Witzel method. Witzel method. In both gastrostomy and both jejunostomy, methods are same. Okay, there are two methods. First is stem method, second is Witzel method. Witzel method. Okay, in stem method, stabbing is present, stabbing, and in Witzel method, tunnel is formed. Tunnel is formed. Okay, like tunnel कैसे बनाई जाती है? Like if you are in jejunum or stomach, directly tube enters here, then it is stab, kind of stab, directly tube enters here. And if you will put the tube through a hole, through this hole you will put it inside, and here you will take some sutures and make tunnels, then it is called as Witzel type of uh, gastrostomy formation or jejunostomy formation. Okay, second is after gastrostomy, second is PEG. One more advanced method is PEG. PEG is percutaneous endoscopic gastrostomy. Okay, these all things we will consider when we will take the next slide classroom, in which I will discuss all the slides and tables from the belly of love. Okay, in this percutaneous method, what we will do, this is tummy, this is your stomach, like, and this one is your esophagus, and this is your nose. Okay, first, how we'll do, we will put the endoscope from this way, and in endoscope, how we will make it, we will put the endoscope through this way, and endoscope will go there, and here we will put one channel, or and through the channel we will put the tube. The endoscope will light here, will produce light here, so we will, can easily see the point of light source from inside the tummy. From the anterior abdominal wall we put the wire, and on the wire we will put the tube. This is called as percutaneous endoscopic gastrostomy. Okay. Okay, next we will go to the different type of complications of enteral nutrition. Okay, now we will discuss the complications 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 of enteral nutrition. Enteral nutrition. Okay, there are two type of complication. First is tube you have kept through the nose in the stomach, the tube related complication. And second is feeding related complication. There are two type of complication, tube related and feeding related complication. Tube can be migrate, so migration of tube is possible. Tube can be blocked, so blockage of tube is possible. Okay, there are two most common type of complication is, first is tube related and second is feeding related. Okay, the most common type of feeding related complication is osmotic diarrhea. Osmotic diarrhea, because most of the time people will overfeed. So osmotic diarrhea will be there. Bloating will be there. Bloating will be there. And if you will feed too much, aspiration of content will be there. And migration and blockage. In blockage is the most common type of uh, complication, tube related complication. So for this type of complication, what we need to do, we need to explain the patient party that explain the patient party that after every feed they need to flush the tube, so it will not be blocked all the times. Okay, then this is the enteral nutrition. Tube feeding, in case of tube feeding, some points should be considered. First, initially starts with initially starts with 20 to 30 ml per hour, not more than that. And slowly you should increase the tube feeding. Okay. Second is there should be a break in feeding at night time. At night times. At night times there is no need to do the feeding. Then this much is sufficient. Okay, nighttime break is sufficient. Okay, now we will Now we will discuss the next type of nutrition is parental nutrition in the next class. Okay, thank you.